Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. Hello and welcome to episode 10, season 3 of the Pain Unfiltered podcast. I am your host, Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, how you doing today?
Patrick, I'm so good. It's been a great day here in the mountain state of West Virginia, doing surgery all day, helping people. And now I get to spend time with 3 of my favorite people. So I'm doing fantastic.
That's great. You know, we have a great discussion today for you guys. First, we want to thank all of our sponsors that have supported this podcast: Mainstay Medical, Saluda Medical, SPR, Spinal Simplicity, Biotronic, and Limbus Health. Tim, we've had a record 6 sponsors this podcast, so it keeps growing and listeners keep growing. So we're so thankful for the listeners and everyone that supported us.
No, Patrick, it goes back to what a great job you've done, and I think you've done a fantastic job. The diversity of topics has been really refreshing. You know, many people tell me they listen to this podcast in the car on their way to work or when they're exercising. I think every time we do an episode, based on your ability to pull out great topics, there's something new. And I think tonight's no exception. So congratulations on what you've done, Patrick. I think this is all about Patrick Buchanan.
I appreciate it, Tim, but no, definitely not. Without your help and leadership and helping with the guests, this wouldn't be possible either. But I appreciate it. So let's go into our topic of the night today. Neuromodulation, obviously a big topic constantly with our patients. It's constantly evolving. And we have 2 experts today to talk about this current state of spinal cord stimulation and what the therapy they use to help improve their patient outcomes. So without further ado, we're going to introduce Dr. Ramo Naidu and Dr. Jason Pope. Thank you guys for joining us.
Thank you, Patrick, and thank you, Tim.
Yeah, thanks, guys.
Ramo, go ahead and just give a brief introduction of yourself and your background, and then we'll pass it to Jason, and then we'll start asking some questions.
Sounds good. So, hello, everybody. Thank you so much for having me on, Patrick and Tim. My name is Ramo Naidu. I'm an anesthesiologist, pain physician. I work in Marin County, which is just across the Golden Gate Bridge from San Francisco. Multidisciplinary group with ortho, interventional pain, physiatry, and I'll pass it off to Jason.
Well, thanks, Ramo. I am Jason Pope. I'm a simple country doctor in Northern California. I took that from Tim. We have a practice in Santa Rosa, have kind of a hub and spoke model where we have major practice in Santa Rosa, and then we have satellites spread out over the Northern California area. I'm an anesthesiologist and also a interventional pain physician.
So, Tim, they're both from California. Please don't hold that against them. But we'll go ahead and start.
Patrick, we love all the California friends. We love all people.
That's great. So we'll start with you, Jason. Can you just discuss in a brief summary what the current state of spinal cord stimulation is and what challenges we face right now with treating our patients?
Well, Patrick, thank you for that question. It's something I've thought a lot about over the 20 plus years that I've been doing pain care. And I've really embraced neuromodulation throughout that tenure. I think we all can appreciate that spinal cord stimulation works for select people. It's been around since 1967. We've had a lot of innovation from equipment to waveforms to sensing to remote care, and it's getting better and better and better. I think when we look at the headwinds upcoming, and those of you that are familiar with Wiser, that is coming out in January, I think it came out, or it's coming out more effectively. It's essentially wasteful and inappropriate service reduction model. It's an initiative to kind of make sure that spending within healthcare is strategically mindful and appropriate. And one of the things that they're really critically looking at is spinal cord stimulation. And I think that part of that may be related to durability of therapy. So I published on reasons why people got their devices removed some time ago. I think, Tim, you were a part of that also. And I see that there is sometimes a poor translation from what we see in peer-reviewed study, whether it's IDE or prospective studies, versus what we see in the real world. Um, and we've all been a part of looking at studies where, 80% of people get 50% relief and 60% of people get 80% relief or more. And I think people are starting to have concern or alarm that we're not seeing that in the real world. And the question becomes why. And so hopefully on the discussion tonight, we'll kind of dive into some of those insights and learnings.
So no, Jason, great thoughts. Ramo, I have a lot of people approach my practice. We have an extremely busy practice here with 6 physicians and 3 sites. And we always hear about, you can bill for remote monitoring for all kinds of things, right? Different things in PT. But I don't think that most of us even understand the exact definition of remote monitoring. What's that actually mean? How does it apply to interventional pain, in your opinion?
Yeah, great question, Tim. So, I mean, I think of our current state of spinal cord stimulation, just to branch off of what Jason was saying, as what cars were like in the 1980s and even before. In that, when all of us, maybe not Patrick because he's younger than us, but when all of us learned how to drive, we had to learn the safety checks, make sure, your brakes were working, the steering wheel, seatbelt, etc. And the only way we knew if something was wrong with the car, right, we kicked the tires around before getting in the car, is if it literally, you heard a pop, you felt something funny or wobbly, you saw steam coming out of the hood. That's how you knew something was wrong with your car. And that's what we have to do currently with every spinal cord stimulator system on the market. But then in the 90s, 2000s, 2010s, we started seeing these alerts on our cars. We saw analog brakes, we saw TPM, tire pressure monitoring, we saw all these different lights and bulbs and signs and signals. Now our cars are telling us before we even know it, hey, there's something wrong. There's something you need to do about it. And that's what remote therapeutic monitoring and diagnostic monitoring is doing for us in spinal cord stimulation. It's telling us in advance, hey, there's something going on. So what remote therapeutic monitoring and diagnostic monitoring is the ability for information to be transmitted through the web, through different methods, to a healthcare provider to inform them on decision making that's going to ameliorate the patient's condition. And that's what Biotronic has brought to spinal cord stimulation.
That's great, Jason. You have patients that live in rural areas. Sometimes it's hard to get to, and you only have a limited bandwidth with patients. I know you're super busy too. How has remote monitoring helped in your practice with your patients?
Well, I'll echo what Ramo has said, in that it's interesting in the world of spinal cord stimulation. We are expecting our patients to signal to us if their device may not be working as well as it possibly could be. And I think that sometimes is unrealistic because they don't know what the therapy is supposed to be able to do for them, or maybe the bounds associated with the therapy. So the issue becomes, and the stagnation of maybe success is related, that all other systems on the market, they have to detect a problem. They have to determine whether the device is supposed to manage that or not. And then they oftentimes have to alert somebody that there's an issue. And then that would then have to be translated oftentimes into an office visit. And based on where they live and where the office is, that can be a really constipated process. And by the time they identify that there may be something going on to the time that there's a therapeutic appropriate intervention, it could be months, it could be weeks. And so I think leveraging a strategy where we can passively acquire information from the patient, active from the device, to allow us to detect if there's a problem with maintenance of the therapy. It allows us to intervene, I think, more appropriately when we do see them, and we can solve those issues from afar. So I had highlighted that I have a hub and spoke model within the practice. So I'm in a little town called Colusa, California, which is a small little town outside of Sacramento, about 2.5 hours away from where I live. So the only way that I can help intervene and care for those people from that distance, knowing that I'm in this place, which I'm currently sitting in once a week, requires leveraging this information and leveraging, I think, the ability to monitor, detect, and treat from afar. And I think that's what I've seen in my practice has been successful in that regard.
Ramo, let me take Jason's answer and your first answer, and I really want to get to the meat and potatoes here, really, of what it means to us as pain physicians. So, I had a patient recently that had a paresthesia-free system. He went to get an MRI, he turned it into MRI mode. He forgot to turn it back on. He came to see me 6 months later and said, "Hey, my device was working wonderful for 3.5 years. In the last 6 months, it doesn't work anymore." So we check him. He said, "Oh, I forgot after the MRI to turn it back on." He hadn't had it on for 6 months. Obviously, it was working. So I think that's a good example of how you don't know what you don't know, right? He didn't know it was off. I didn't know it was off. And if he'd gone to see some other practice where in West Virginia, where we don't lose our patients very often because there's not many competitors, we don't need to worry about that. But in some cities, he would have been explanted as a failure, and it wasn't even turned on. So I know you you mentioned Biotronic. You had I think it was you did a study there, a couple studies, and the last one I think was called Benefit 3. What real world data and what level, high level data do you have to show us the benefit is real and not just a philosophy? I believe it after seeing that patient that it can be very real, but is there data from Benefit 3 and other studies that there is a real proven clinical benefit here of remote monitoring?
Yeah, great question, Tim. So I think the approach that Biotronic has taken on this very topic is number one, let's get the level 1 study out. As you mentioned, it's called Benefit 3. This is out of Australia. The 2-year data has yet to be published, but it's there. We have some early analysis on Benefit 3 for the first few patients regarding how they like remote programming and monitoring and how they like the resonance stimulation paradigm. So to answer your question, like what is the true benefit from Benefit 3, that's still to be determined, to be honest. Some of the things that have come out that we've gleaned from abstracts from society meetings is that number one, patients like it. They appreciate having the remote therapeutic sessions because they don't have to drive, saves them time. The average length of time of these sessions is several minutes rather than, as Jason alluded to, you might be sitting in the clinic for an hour and a half or 2 hours getting reprogrammed. So we've heard all of these anecdotes. I look forward to the publication that will really distinctly say what is the major advantage with this. Now, on the other arm of this and Biotronic's approach is, all right, since April of 2023, the first IPG was implanted, we can glean data from the real world. That is, everybody who's getting implanted in the United States of America right now, we know exactly what's happening as far as these triggers that have been designated, electrode impedances, therapeutic range, whether the device is on or off, as you alluded to, how much charge is in the battery. All those things are being ascertained every single day automatically. And so we have, and Jason's, the lead author on this paper that's going to be published in Neuromodulation soon, regarding all the triggers that have been triggered and how quickly we've been able to intervene and, again, reduce that time where patients may lose belief in their therapy and also relief in their therapy.
No, great thoughts, Patrick. Give the next question. I have to say, Jason gets the award for best hat on the podcast of all time. Patrick,
maybe the only.
That's great. So, Jason, Ramo talked about kind of the high level studies that's going on right now. You've actually had experience and just published recently the real world data on some of these measurable effects that you're seeing in patients with remote monitoring. Could you talk a little bit about that?
Yep, I'm happy to. Thanks for the question. So one of the challenges with spinal cord stimulation, and again, kind of echoing the introductory comments, is the fact that we didn't really have a very good way of granularly knowing what was the destiny of the device. And so when we're leveraging a technology that allows us to know more granularly where these devices are, Are they in the patient? Are they out of the patient? Are they on or are they off? Are they using the therapy? Has the therapy been off? How long has it been off? It allows us to, I think, define a lexicon that we've never been able to accomplish in the past to describe really what is the explant rate. We all know, and Lawrence Perret, a good friend of the group here, he described a strategy saying that when people get their devices removed, they oftentimes go in the trash can, and it's very hard to create a streamlined approach for reporting. So sometimes those are overreported or underreported. It's kind of hard to tell. So when we're leveraging a technology where you know where the device is at all times, you can start to put, I think, more firm numbers associated with it. And that was the intent of the publication of the first 500, looking at really defining a lexicon and comparing explant rates to what we saw in the first 500, leveraging this technology versus what was historically published. And then also diving into what is the virtual explant? Like how long, what is the likelihood that someone would have a device and they're not using it? And we went into defining how long it is before we say it's a virtual explant versus not. But long and the short of it, to keep this really simple, I would say that leveraging this strategy where you're proactively intervening and maintaining the therapy therapeutically from afar, what we saw was in the first 500 that we saw 50% reduction of the reported explants over the course of a year. When you look at Van Buiten's work, it essentially it gravitates towards about 11% of people that get their devices in are removed within a year. We saw 50% reduction of that. We saw people that had their devices removed because of lack of efficacy also decreased by at least 50%. And that was down to 2 to 2.3%, which is something we've never seen in the space before. And then when we look at defining this lexicon, we see that less than 1% of people of the first 500 within the first year aren't using their therapy, which is something we've not seen before. And so I think defining this, we're getting more granularity with how people actually use spinal cord stimulation. And we've never had the ability to really take a look before.
So, Jason, I want to take those points you made, and you and I worked together when you did your study, which is very similar to what you just reported from Van Buiten. But Ramo, I'm going to set this up by telling you a couple of stories. I'm going to ask you a question, okay? Story number one is we have medical students now. We have 2 different med schools. We have all their students. So we found that our 5-year explant rate in our practice was around 6.3% total for 5 years. So very pleased with that. I think it's definitely a best in practice type of number. But Jason pointed out to me, I have a great team of reps who reprogram people frequently when they need it. And we get them back in, see a nurse practitioner, we get x-rays. We very proactive on these patients. We see them every 6 months, just to keep track of them when they're doing well. And that's hard to do in a lot of areas of the country. And I know it's difficult. Story number 2 is I saw a guy today, he'd had his device off for a year because he didn't need it anymore. After 4 years, his pain that we put it in for had gone away, which was post-laminectomy leg pain. He said, Doc, I came back to see you because I quit using it because my pain went away. But now I have this terrible neuropathy in my feet. It's killing me. And I said, well, guess what? It may help that too. We'll turn it back on today. So I had no clue about the explant rate until the students looked at it. Had no clue about this guy not using his device anymore. He didn't quit using it. He didn't think he needed it anymore, but he has a new problem now. But I do think that the proof is always in the pudding of the practice, right? So if it works for Patrick in a very fancy part of California, it may not work for Jason in that small town he's in because he's a simple country guy. In your practice, you have the most experience of the 4 of us on this podcast using this remote monitoring biotronic in clinical practice. What has it done for your practice that's valuable? And how do you think that will extrapolate to other practices going forward? That was a long introduction, but I think I gave you a couple of examples of, I have a low explant rate, but it takes a lot of work to keep that. And then I had a guy not using it. I didn't know that, but he was doing well. And then here you are using a way to modulate people. Last part of that story, this is probably the most important part I forgot to tell you. I had a doctor visit me a month ago to watch me do SI fusion from a big city. And he said, my patients do well, but the guy across town from me, this is a true story. You're going to appreciate this. The guy across town from me is terrible. I explain his patients all the time and revise them to another system. Well, a month earlier, he didn't know this. I had a guy come to watch me do stimulators, and he said, to learn DRG, and he said, my back's doing great. I got this guy across town. I explain his devices all the time. He's terrible. These two guys hated each other, and they both said the other guy sucked because their patients just swapped where they went, right? And they had no clue that they lost track of their people. They assumed their people were doing well, and they weren't doing well. So that's another example of what our problem is, right? What's your experience?
Well, there's a lot to unbox there, Tim. So,
Sure
number
is.
one, I mean, to answer your question of what's the greatest value I've seen in the last 2.5 years, number one is the time I've saved in managing SES devices in my practice. So, number one, historically, if there was an issue with a patient stimulator and the device rep, tried to reprogram, couldn't get anything, better or ameliorated, and they were concerned about lead migration, you have this algorithm, right, for SES not working, right? Get x-rays, reprogram in-house, figure out, has the pain generator changed or whatever else. That takes time. And a lot of that is after, as Jason mentioned, some delay of a week or two trying to get into a busy practice, and they're getting pissed off, and you're trying to do the best you can. So what I've seen in the last 2.5 years is the number of follow-up visits has reduced. I still do my every 3 month, 6 month, and annual visits with them, but all the extra stuff has reduced. I'm also seeing a lot more patient satisfaction in that, as we've talked about, the time to resolution or to be contacted has reduced significantly. They're not dependent on that one rep who might take vacation to Japan for several days. There's always someone available, wherever they are in the country to get a hold of. So I would say time savings and then the frustration of patients has been the biggest key thing. As you alluded to, I used to track my data as well, but guess what? I had to do it manually. I'd have my MA do it. I'd have a rep do it even sometimes, and then they would change or my MA would change and I wouldn't have time, and then we'd fall behind by 3 months. It's super time consuming. It's amazing you got that data. It's great data. 6% is outstanding. But as you know, there's a lot of investment in that time to do that. This is automated. This is just done for you. You can just quickly look up the information. It's there for you. And if you want to look back 2 years, 1 year, 6 months, if you want to look at, now I've got other providers who are doing these devices. I can look at our whole group. I can look at me as an individual. Anonymized, I can look at the whole San Francisco Bay Area. So being able to look at all these data has been huge and a lot of fun, actually.
That's great, Ramo. Yeah, anecdotally for me and my patients, I think patients' compliance has improved as well. I see a lot of elderly patients as well, and charge burden can be tough. And when these patients are charged, they can be reminded, and the staff also can be reminded, and making sure these patients are charging their devices properly as well. So we've seen patient compliance increase as well. So that's been great. So as we wrap up this, we'll ask just a couple more questions, one for me, one for Tim. We'll go with you, Jason. I always like these forward-leading questions. Where do you see, neuromodulation and even remote monitoring progressing in the next 5 to 10 years?
Well, I think that in the age of neuromodulation where we are, I think we're really going to have to leverage big data. And I think that when we have the ability to remotely assess and intervene from afar, and attaching validated PROs to every patient that's implanted commercially, I don't think that there would be any headwind that we couldn't attack, looking at the opportunity for indication expansion, looking for finally saying once and for all that spinal cord stimulation is helpful in treating axial low back and radiculopathy or CRPS or the like. And I think that's the future. I think the future of spinal cord stimulation is big data, and it is collecting the same type of data and then aggregating our results. And I know that Biotronic has taken the lead in leveraging that strategy.
Jason, great thoughts. I agree with everything you said. I'm a big data guy, as you know, and I have a few publications pending on big data, which will be, I think, helpful to all of us. So, Ramo, last question from me, and then we'll have our final thoughts. So, I do think that there's trends and fads. Okay, so when constant current came out, people switched from constant voltage. When people came up with paresthesia free, a couple, HF10, which I designed the Senza study with a couple of folks, and then we had the Sunburst study. People switching on paresthesia, right? Then they back and forth. Then you had things like closed loop, and the question is everybody going to need closed loop down the road for their waveform? And the answer is yet to be determined. And now we have remote monitoring. So my question for you is 2025 right now? In 2030, will every company have to have remote monitoring? Is that going to become the standard of care?
I think so, Tim. I think this is the next wave for all spinal cord stimulation. Just like I made the analogy with cars these days having all these monitors and sensors, and we're accustomed to that, and it really has made our experience better before our cars blow up or steam up or whatever else. I think the value proposition is really obvious, and it will get into every other company's portfolio. The challenge for every company, though, is that you've got to re-architect your IPGs and understand connectivity issues through cellular and Wi-Fi networks and build that in. So it may be a few years. There's a moat that Biotronic has right now where it may be, until 2, 3, 4, 5 years later where the other companies will adjust. But I personally feel like as more time goes on, more big data comes out from Biotronic, everyone else is going to be looking at that like, hey, we got to be on this ship because if we don't catch it, we're going to drown.
That's great. Yeah, I agree with that. Thank you guys so much again for joining us today with this great discussion. We'll wrap it up and then we'll have Tim this time have the last word for you. So I just want to thank Jason and Ramo, our guests, for coming on. You guys, I view you guys honestly as two of the leading experts in neuromodulation in the entire world. So the way you guys evaluate companies, evaluate technologies, and then back it up with the data, the real world data, keep doing what you're doing. You inspired me. You inspired a lot of young physicians as well. So I appreciate all you guys' work. And then we'll get your final thoughts, Jason, Ramo, then end with Tim.
Patrick,
Jason,
thanks for those kind words. I remember some time ago, you and I did a real world data set looking at trialing different therapies and changing the sequence and how people got to them to kind of determine if there was an efficacy measure associated with different waveforms and strategies and whatever else. And I think, again, I would like to empower everyone to say that you are the stewards of spinal cord stimulation. You're the stewards of, I think, being responsible in how you select for it, how you trial it, how you look for prognostic utility of the trial, and then how to, I think, really focus on the durability of the therapy. And it's not just durability where they've maintained their device. It's successful therapy for the long term. And I think that when we look at new technologies that are coming and new technologies that are here, I think we need to really embrace and focus on leveraging the next step. And hopefully that's what we talked about tonight.
I'll just say, being on this with you three is amazing because Tim, you've led the way for decades, not to date you, but just imagining where you were when you were our age or younger and where we are today in spinal cord stimulation is quite a miracle, in my opinion. Just our ability to get all of this data on demand and where are we going in the next 5 to 10 years? If you guys have been playing with Gemini and Grok and Claude and OpenAI and ChatGPT, the things we're doing these days, you can just ask questions, you're getting answers. Imagine what we're going to be able to do with spinal cord stimulation and the data we have, and then we layer on top of that AI analysis. We can ask all the questions in the world regarding all the demographics, emotional scales, psychological scales, pain areas, types of pain. And we're going to be in a new era of pain management where a lot of our colleagues, as anesthesiologists or whatever, really scrutinized our field for being wishy-washy. Oh, pain is subjective. You don't really know. Well, we all jumped into the complex, and all it took was more growth, evolution, investment, And now we're going to see some really cool things that are really going to help people in amazing ways. So this is a really exciting time. I think remote monitoring is a big step towards that. But I'm really looking forward to the next 5 to 10 years, because when we get all this data, we're going to be doing amazing things.
Yeah, no. So Ramo, thank you for those comments, and I agree with everything both of you said. So I think that we really have seen evolution of our field. And I think that one thing that I do believe now more than I've ever believed is that we have to make this a durable therapy that when you get it, you expect it to do well for many years. Okay, so there's many pieces to that. Recently, I had a friend buy a new home and buy a refrigerator at Lowe's. Now, why am I closing with this comment? 7 years later, the refrigerator broke. The warranty was 5 years. And I thought back to my mother-in-law, my mother, other people. They get a refrigerator at Sears. That thing would last 25 years, right? Things don't last very long anymore. And people have accepted that nowadays, right? Because that's just how long things last. But for your body, when it doesn't last, you have to have another surgery. It's very serious for your body, right? So it's different than, I think we've done poorly with a lot of equipment. So I do think remote monitoring, I asked you this question earlier, Ramon. I'm going to give you my answer. I think in the next 5 years, every device put in people's bodies will have to have this capability. And I know it takes a reworking of generators. I know it's expensive. But if we want this to make this a durable long-term therapy, we have to know what's going on. And I do think that what we need to have come together is data publications from the data you have that you mentioned tonight from Biotronic. They need to publish that, show a difference. And then other companies are going to have to come along and step up to that same point. So to me, it is a new revolution. It is going to be needed for all devices. I think by 2030, it should be the standard of care to have this in all devices, because I need to know what's going on. And people are going to be mobile, moving, old, home, charging, not charging. We need to know. If we know, we can fix problems early before they become an explant, which is bad for everyone, the patient, the doctor, the insurer, and society. So I think you two gentlemen tonight did a fantastic job, as I knew you would. You've set the bar for where we need to go. You've explained why it's important. Now we need the publication of short-term data and big data to show it makes a difference. So Patrick, great job tonight. I'll give you the final thought as we close.
Yeah, thanks, Tim. Yeah, I reiterate what everyone says. I think that is the future of not only medicine, pain, and all the technologies that we kind of build from here. So thank you guys all for joining us. We had another great conversation on the latest technologies in our field. That wraps up another episode of the Pain Unfiltered podcast. Thank you guys all for joining us.